So today I'll be speaking on the looking at the management of HER2 negative early breast cancer. What is the anything news which is happening in the precision medicine? So the topic is very uh, clearly about redefining the strategies, especially to treat HER2 negative early breast cancer in the era of precision medicine. We have been talking about precision medicine more into HER2 positive, not in the HER2 negative diseases. So today we will talk about different trials and like Olympia, Brightness, S5CC, S5CC, CallGB, Keynote, Impassion 031, and Monarch and Penelope and the Palace. Because what is happening is that now in the early breast cancer, we are trying to incorporate any kind of adjuvant role of capecitabine after the chemotherapy. We are trying to see whether all these CDK forces can be part of it, because this is a HER2 negative and ERPR positive, and the role of immunotherapy specifically for this subset of group of patients. So, looking at the background, we know that the early breast cancer, they have high survival rate as compared to advanced disease. No need to mention about it. You can see in the graph that the orange one is the one which is looking at the early breast cancer. You can see the survival of the metastatic advanced diseases. So, and there are different options which have now come up in all the therapies. Now we have neoadjuvant surgery and radiation therapy. So normally we divide the HER2 negative into three subset. We call it luminal A and luminal B, based on the both are HER2 positive, but based on the certain other characteristic, and the triple negative breast cancer. Triple negative breast cancer is totally different thing, but we'll be discussing briefly about that part. So my today's talk will be morely focusing on the luminal A, B, and the triple negative. So this is how the things have evolved. We are very clear with the role of neoadjuvant chemotherapy in the triple negative. In a case of HER2 positive luminal A and B, HER2 negative cases, the still the role is not so well defined, but the role of surgery and adjuvant therapy is more prominent as compared to triple negative, where the role of neoadjuvant has become like a standard norm. Second thing important is that, talking about the BRCA mutation status, and looking at the prevalence in unselected breast cancer patient, it is coming to approximately 5%. So individual studies in this unselected breast cancer population, they have shown varying frequency. You can see in different in different countries, you can see the difference in the BRCA mutation prevalence. But overall, it is coming to around 5% of breast cancer patient will have BRCA mutation status. And if you look at the Indian papers, there are the two papers I have just quoted. One was which was published in a little bit earlier by the AIMS group. Another is from the group from the PGI Pondicherry, basically. And if you see here, the AIMS group, they had shown that the prevalence is higher in the Indian patient as compared to most of the population, and the data which is available suggests that nearly 50 to 80% of the individuals are at risk of having a hereditary breast cancer, and they are never tested as they do not meet the current criteria. So, looking at the BRCA mutation status by the NGS in the South Indian patients, they had specifically looked at the triple negative breast cancer, and out of the nearly 59 patients, they found that the BRCA mutation was identified in around 13.6 patients, and in BRCA1 mutation in 6 patients, and BRCA mutation 2 in 2 patients. So in a HER2 population, it is very important to do the BRCA mutation, and we know that patients with BRCA, they have a different tumor characteristic as compared to sporadic. We know about his aggressive nature, and they are diagnosed much at a younger age, and the grade is also on the higher side. They have more commonly CNS metastasis. The probability of developing a contralateral is very high, and they have a high risk of recurrence also. So in an early breast cancer setting, what is most important thing is that BRCA status does help us in making a decision around surgery and targeted therapy. We are now with Olympia's trial, we are very little bit, we are very clear about the role of olaparib in a certain high risk group of patient for adjuvant olaparib. But if a patient has got a BRCA status done before the surgery decisions are taken, you can change the surgical decision also. And the from going from conservative to the mastectomy is something which most of the people do it. So doing BRCA testing early upfront is something now day by day becoming is a norm. And we know about these things, that the pre-operative genetic testing does impact the surgical decision making, and that I think we should, it might over the period of time become a norm over the period of things. Now, what does the NCCN criteria talk about the BRCA testing? They have divided into less than 45 years, less than 50 years, more than 50 years, any age. And they look into many criteria. They look into the personal history, family history. Any patient has got a additional breast cancer primary. So these are the criteria which at any age we normally look at it. Especially now after the olaparib has come into the place, so doing a BRCA testing upfront is also part of it. Most of us have been doing it for the triple negative breast cancer. Male breast cancer also are more prone to have a BRCA testing. So these are the subset of population where in an early breast cancer setting, basically we should get the BRCA testing done. So one of the early trial which basically laid the foundation for which was, I will call it, practice changing trial, which laid the foundation for the role of doing BRCA in early setting, is this Olympia study. It was a phase 3 study of olaparib versus placebo as adjuvant treatment for this high risk, especially high risk. Will define the high risk germline BRCA mutated HER2 negative breast cancer. So they had taken a stage 2, stage 3 patient, HER2 negative, those which have completed local treatment and more than 6 cycles of neoadjuvant and adjuvant chemotherapy. They divided into neoadjuvant and adjuvant group, and 4 high-risk population were taken into place, and it was randomly divided into olaparib versus placebo. The primary endpoint was the IDFS, invasive disease free survival, and also they looked at the other key secondary endpoint like OS, DDFS, and the health related quality of life and other parameters. So they had they had defined the high risk based on the Olympia trial gave a criteria for high risk. So they nearly 82% of the patient were triple negative, and the criteria for a high risk in this patient was that if they were treated with adjuvant chemotherapy, were required to have axillary lymph node status or an invasive primary tumor at least 2 centimeter on pathological analysis, and if they were treated with neoadjuvant chemotherapy, were required to have a residual invasive disease in the breast or resected lymph node, no PCR from the neoadjuvant therapy. Nearly 18% patients were HER2, and the criteria here was if they were treated with adjuvant therapy, were required to have at least 4 pathological confirmed positive lymph nodes, and if treated with a neoadjuvant chemotherapy, they were required to have not have a PCR with a CPS EG score of 3 or higher. So this CPS EG score came into the prominence after the Olympia trial. Basically, this system estimates a relapse probability on the basis of clinical and pathological stage and ER status. So the G is your histological grade, E is the estrogen receptor status. Any score which is ranging from, the score used to range from 0 to 6, with the higher score indicating that there is a worse prognosis. So the CPS and EG score, you can see over here, how do they calculate, and it is nothing but the sum of the point score of the clinical stage plus pathological stage plus ER status and the nuclear grade. So what does a trial basically look into it, and the results showed that the olaparib reduced the risk of invasive recurrence or death by nearly 42% versus the placebo. You can see a 1-year treatment cap here, 88% as 93.3 as compared to 88.4. And so the 3-year, if you see the IDFS rate, it was around 85.9 as compared to 77.1, with a difference of approximately 8.8%. and with a very clear hazard ratio of 0.58. So there was a consistent benefit which was seen across all the IDFS group. Uh, Patients who had taken neoadjuvant or adjuvant treated with prior platinum, they had less benefit, but it favored olaparib as compared to no platinum. And patients who are HER2 positive, basically those who are triple negative, had a more better response as compared to hormone positive and HER2 negative disease. Patient who had BRCA1 or 2, it never impacted so much in the way of the HR ratio. And looking at how many were free from the distance recurrence or death at 3 years, nearly 87.5% patients who were treated with adjuvant olaparib for 1 year, they were free from the distance recurrence or death at 3 years. And you can see a secondary endpoint of DDFS, which is distant disease-free survival, and the hazard ratio was 0.57. The difference at 3 years was around 7.1% in the patient who had taken olaparib and those who have not taken olaparib. There were also fewer deaths reported in the olaparib group compared to placebo. And even though the OS also showed a slightly better rate at 3 years, around 92 as compared to 88, with a hazard ratio of 0.68, but the difference in OS did not achieve the threshold for statistical significance in this pre-specified multiple testing procedure. So OS was not so improved with it. Now, another important thing is the adverse event, whether they were, how bad they were, but most of the adverse events were mild and moderate. We know with the PARP inhibitor, one of the most important side effects are related to nausea, fatigue, and anemia. And naturally, they were higher as compared to the placebo. And anemia was the only grade 3 adverse event occurring in nearly more than 5% of the patient. Most of them, basically like nausea, fatigue, were more of early grade, not grade 3. So grade 3 around in anemia was the only one which was around 5% of the grade 3. And there was no clinically meaningful change in the fatigue severity across the duration of the study. And fatigue is something which we tend to see with the olaparib, and the pre-specified clinically meaningful difference is 3 point, and it was not met. So patients who were treated with olaparib, they had slightly more fatigue as compared to placebo. A difference was statistically significant, but not clinically meaningful. So the FACIT fatigue score, you can see it over there. So another part is the nausea and vomiting. The meaningful difference, clinical meaningful difference in nausea and vomiting was small, and whenever you used to stop the medicine, the difference used to go away. So there was no clinical meaningful change in the diarrhea quality of life score between the olaparib and the placebo. So the nausea, vomiting, diarrhea all had a equivalent clinical meaningful difference. There was another trial which looked at the addition of PARP inhibitor veliparib, which was combined with carboplatin or carboplatin alone to a standard neoadjuvant chemotherapy in triple negative breast cancer. That is called brightness study, which is a phase 3 study. The key inclusion criteria were patients who were more than 18 years, stage 2, stage 3 triple negative patient, and those patients who were potentially curative surgery with documented germline BRCA status. So they had excluded patients basically with the previous anti-cancer therapy and previous or concurrent cancer. So these are the 3 arms in which they divided when randomized into 2:1:1, and they had given Pacli plus carbo plus veliparib, Pacli plus carbo plus veliparib at basically a different dose, and also Pacli plus carbo placebo with the veliparib. So, and later on the segment 2 was AC and the surgery. So the main endpoint, was looking at the pathological CR, and efficacy was assessed in all the randomized patients, and safety in all the patients who received more than 1 dose of carboplatin. So this is the final answer from this trial. Like when you add carboplatin to paclitaxel followed by doxorubicin AC, it improved the pathological CR significantly, and it translated into an improved EFS after a median follow-up of around 4 years. So when you add veliparib, it did not impact the pathological CR. So the impact was more when you had Pacli plus carbo followed by AC as compared to adding the veliparib over there. So NCCN and ESMO guideline both recommend. There's one more thing about especially in a, so this is the one thing about the triple negative patient looking at the pathological CR when you add veliparib or not. The another thinking is since the patients are having triple negative, whether based on the pathological CR, whether to incorporate the usage of capecitabine in a routine practice. So based on the phase 3 create X trial, basically uh, uh, the role of adjuvant capecitabine came into place, and create X trial basically when the adjuvant capecitabine was given, it improved the survival in this particular group of patients who had residual disease after the standard NSCT. So you can see guidelines, but do not currently recommend capecitabine use in a HER2 positive, HER2 negative and HR positive. It is more meant for the triple negative cancer as compared uh, uh, to this particular subset, that is HER2 positive, HR positive and HER2 negative. So one more trial looked into whether we can give the low dose capecitabine. So that was just SYS UCC 001 randomized clinical trial. The question which this trial basically tried to answer it was, does therapy with low dose capecitabine maintenance after standard therapy basically reduce the risk of relapse and death among patients with early stage triple negative breast cancer? So they had taken around 434 patients of a median age group of 46 years and different locations. This study was more in China, different location in China they had taken, and they had given a low dose capecitabine of around 600 milligram per meter square twice a day by mouth for 1 year. And these are the 5-year disease-free survival. You can see as compared to observation, capecitabine hazard ratio of risk of recurrence or death was in the range of 0.64. So this trial basically found that patients who are early stage triple negative breast cancer, maintenance therapy with a low dose capecitabine significantly improved the DFS at 5 years. Most of us have started using capecitabine in our routine clinical practice also. Now, another trial looked at standardized standard adjuvant chemotherapy regimen versus capecitabine in older ladies with early breast cancer, because we know that sometimes it becomes very difficult for them to take chemotherapy. So this CALGB trial tried to address that in a ladies who are more than 65 years, early breast cancer, and those patients who are having basically adequate hematological renal and hepatic function. This trial basically tried to compare the standard chemotherapy versus capecitabine. The dose was quite high, around 2000 milligram per meter square per day for 14 consecutive days every 3 weeks for 6 cycles, and it was compared with CMF or AC. Around 600 patients came into pairs, and there was around the primary endpoint was a recurrence-free survival, non-inferiority of the capecitabine. You can see the Kaplan-Meier plot for the recurrence-free survival and the overall survival, and the difference, the hazard ratio was around 0.84 in the recurrence-free, and for the basically the OS also it was 0.84, slightly improvement over there. So, and another thing which people are looking at it, whether what is the role of immunotherapy plus chemotherapy as neoadjuvant therapy, in the role in early stage triple breast cancer. So, Keynote 552 was a phase 3 trial of pembro and chemo as neoadjuvant therapy, and pembro monotherapy as adjuvant therapy in early stage breast cancer. So this was they specifically took newly diagnosed triple negative breast cancer with nodal positive status and ECOG performance of 0 to 1. So this is they had given 4 cycles of neoadjuvant chemotherapy with pembro plus paclicarbo, and also they have given neoadjuvant chemotherapy with the AC also with pembro, and later on adjuvant with only pembro. So the primary endpoint here was looking at locally assessed pathological CR and also looked at the EFS, investigator assessed EFS. And secondary endpoint was to look at pathological CR in a T0 N0 disease also, and also in the OS in the ITT also. So this is the prior analysis of the keynote trial. You can see the pathological CR uh, in a this particular subset of patient. You can see the pathological CR rate was around 64% as compared to 51. This is the first EFS analysis for this group, and updated finding demonstrated that there is a robust treatment benefit with the experimental regimen in the EFS sensitivity analysis. Most of the analysis favored basically pembro plus chemo, followed by adjuvant pembro. Still a long way. I feel that the role of immunotherapy is there in the neoadjuvant setting. Impassion also looked at the all this trial basically came into place after they found some success in the metastatic setting. So Impassion 031 was a phase 3 study, and it also looked at whether atezolizumab with chemo as neoadjuvant in early breast cancer, does it work or not. So similar, they had taken a triple negative patient with more than 2 centimeter, any T2 disease and above, any N0 disease with a good performance status. Also, they had stratified based on the stage 2, stage 3 PDL1 status less than 1% or more than 1%. So this is a schema here. You can see nearly more than 300 patients they took it. They had given atezolizumab with nab-paclitaxel. Specifically, they selected nab-paclitaxel because the usage of steroid was not there, followed by AC, and then atezolizumab as a adjuvant therapy. And they looked at the pathological CR in this particular group, and also they looked at pathological CR in a PDL1 positive patients. You can see the pathological CR in all the different groups, especially in the PDL1 negative, PDL1 positive, and in a patient with triple negative breast cancer, when we are combining the immunotherapy with chemotherapy, it significantly increased the pathological CR regardless of the PDL1 status. And you can see here in a PDL1 status, positive cases, difference was slightly more as compared to PDL1 negative. Overall, also it was showing a positive status, even though there was a numerical increase in the pathological CR when you add in a positive patient as compared to negative tumors. The OS was not reached in any treatment arm, both in the keynote and the Impassion trial. This is very important thing to understand, that both the trials basically looked at the OS, but the OS was not reached in any of the treatment arm, even though it was a secondary endpoint. And when we talk about the immune-mediated adverse event, it occurred in both the group. So it occurred in the keynote. You can see the infusion reaction and hypothyroidism, severe skin reaction were very common. And even here in the atezolizumab, the most common was a rash and the infusion-related side effect. And some of these adverse events observed in these two trials, they could be very severe, irreversible, and they require long-term medication with potentially potentially curable breast cancer. So patient, there is a chance to develop diabetes, hepatitis, GBS, and also the hypothyroidism and adrenal insufficiency. So you can see here that they also looked at the death due to immune-mediated adverse event. Remember, these are all curative patients, and in a pembro arm, basically there were some patients who had death, around 5 patients, and basically there were no deaths related to adverse event in the Impassion 031 study. So approximately 1 in every 4 patients in the IO arm, they have to discontinue treatment early due to adverse event. And in both the arms, the rate of discontinuation due to adverse event were higher in the keynote and the Impassion versus trial of pembro in the metastatic. So as compared to metastatic setting, in a neoadjuvant setting, the adjuvant setting, the discontinuation was more. Patients who were early breast cancer, they were less tolerant to adverse event than those with the metastatic breast cancer. Another thing is to look into that those patients who are hormone positive, HER2 negative, whether we can incorporate CDK4/6 as part of the therapy. So this is a Monarch-E study which specifically took this particular group of high-risk early breast cancer, those who had taken with or without prior adjuvant chemotherapy, nodal positive status more than 4 axillary node or 1 to 3 axillary node, and at least one of the following tumor size more than 5, histological grade 3, and centrally tested Ki-67 more than 20. So also those patients who have finished 12 weeks of ET after completing last non-ET. So they had divided into two cohort. Cohort 1 based on the clinico-pathological risk factors, and cohort 2 based on the Ki-67 and also other factors like lymph node status. So one group they gave standard of care ET with Abiva, which was given at 150 milligram BID up to 2 years, and they compared it with the standard endocrine therapy. The primary endpoint was the IDFS also, and the secondary endpoint was the IDFS for participant with the Ki-67 more than 20 and DRFS and OS also. So we see the IDFS and the distant RFS, the result, and when they had abemaciclib was used with endocrine therapy, demonstrated a statistically improvement, significant improvement in the IDFS versus the ET alone. The 2-year rate is around 92.3 as compared to 89, and also improvement in the DRFS in the Abiva plus ET compared to ET alone. And one of the most common side of distant recurrence with the bone, liver, and the lung. So IDFS benefit was maintained with additional follow-up in the intention to treat population, and there was a 30.4% reduction in the risk of developing the IDFS event. The difference, if you see the absolute difference between the arms, was around 5.4% at 3 years. And looking at the safety profile, because Abiva is a not so easy drug to give, and the safety profile was consistent with the previous studies, and the level of diarrhea was also on the higher side, and nearly 17 to 18% of the patient on the CDK4/6, that is abemaciclib, they had to discontinue therapy due to adverse event after a median follow-up of around 19 months. And you can see the most common side effect was diarrhea followed by fatigue and arthralgia. So nearly 20% patients had to discontinue this therapy. Another study was looking at the role of palbociclib, that is called Penelope study, Penelope study, which looked at the role of 1 year of palbociclib treatment versus placebo with endocrine therapy in patients who are high risk, those who have got high relapse risk after the NSCT. So they looked at the CPS and EG score patients who had taken prior NSCT and no pathological CR after the NSCT. So the group there selectively selected was no pathological CR after NSCT. Remember, in a hormone positive, HER2 negative, probability of getting a pathological CR is very less post NSCT. So Palbo was given for 1 year for around 13 cycles along with endocrine therapy. They looked at the IDFS, and also they looked at as a secondary endpoint the IDFS excluding the second primary invasive non-breast cancer, also looked at DDFS and other parameters. So Penelope study, what does it answer? Looking at the invasive disease free survival as a primary endpoint. So palbociclib for 1 year in addition to endocrine therapy did not improve the invasive disease free survival and OS in patient with the residual disease after the NSCT. So this was basically more of a failed study. It could not show any improvement in the IDFS and the OS. Another study was a PALA studies, which looked at the addition of palbociclib to ET in the adjuvant setting. Here they have taken this, they have taken patient with hormone positive HER2 negative breast cancer and completion of prior surgery with or without chemotherapy within 6 months of starting adjuvant endocrine therapy, within 12 months of diagnosis. So they have randomized with palbo with ET and plus minus LHR agonist as compared to the standard arm of ET. So similar IDFS and the other parameters. Palbociclib was treatment was continued up to 2 years, and ET was given for more than 5 years. So addition of 2 years also did not improve the invasive disease survival. You can see it here, and also the distant RFS compared with adjuvant endocrine therapy. So 1 year of palbociclib or 2 years of palbociclib did not show any kind of improvement. So the final analysis data also confirmed that longer palbociclib duration or more than 70% dose intensity did not markedly improve the IDFS. So you can see a hazard ratio of 0.96. And in this subset of patient who had basically those with the germline BRCA status had comparable outcome with the wild type patients. So looking at the safety profile, it was consistent with the previous studies, including we know that neutropenia is something which is common, high levels of grade 3, 4 neutropenia, although the grade was common, febrile neutropenia was very uncommon, we know about it. But the thing to understand is that nearly 42% of the patient had to discontinue treatment early at the time of the second interim analysis of PALAS. PALAS had slightly more dose, and also it was given for 2 years. And you can see the adverse event here. You can see the neutropenia, leukopenia, fatigue or something are very common with palbociclib. And patient who received palbo in the Penelope B experience a higher incidence of hematological problems. We told nearly 80% in the palbo arm completed treatment, and nearly 20% basically had to discontinue treatment. Remember, in a Penelope B, it was 1 year of therapy. So I think I had come to the conclusion, specifically in this particular subset where you have treating luminal A, luminal B, and the triple negative, where we are, what is the standard thing which is coming, how much is the role of adjuvant capecitabine is needs to be discussed. So the recent development in our understanding of breast cancer, molecular biology, and heterogeneity have led to a lot of substantial improvement in outcomes. The value of identifying the thing which has happened in the last few years is that we have started understanding the value of identifying a high penetration mutation in breast cancer. It's become well established, and germline BRCA mutation status we need to identify, and it has gone beyond beyond prevention to treatment in both early stage and metastatic breast cancer. Previously, it was meant only for the metastatic breast cancer. Now it has come for both the early stage and the metastatic breast cancer. And Olympia trial basically reported was a first trial, phase 3 trial, reported the benefit of this PARP inhibitor adjuvant treatment in a patient with germline BRCA mutation, HER2 negative early breast cancer who are at high risk of recurrence. They had a high risk criteria. We have to follow that criteria whenever we are giving the medicine. And there are other trials, seminal trials with IO immune check inhibitors like Pembro and atezolizumab in combination with neoadjuvant chemotherapy in early triple negative breast cancer. And also, like I presented the Penelope PALA studies, those with that CDK4/6 where they use abemaciclib and palbociclib in addition to endocrine therapy. In this particular group, they provide data that things over the evolution of treatment strategy in the early breast cancer, even though they are not still the standard which we use it. So understanding the role of these agents in the light of existing therapies allow us to optimize the treatment strategies in a way so that we can achieve the best outcome for the patient. The only thing which is positive in this particular subset is the role of PARP inhibitor and the role of capecitabine in patients post surgery, looking at the residual pathological CR and the role of capecitabine over there. So still other therapies like immunotherapy and role of CDK4/6 is still evolving, and over a period of time we will know, but till now the data is not so robust to include in our clinical practice. Thank you.